Pathology of the orbit, injuries of the eye. Firstly, let's remember to each other what is orbit. It is a bone receptacle for the eye. The shape the shape of the orbit is a four-sided pyramid facing the base forward and outward. Four walls: inner, upper, outer, lower. There are several bones which complete this structure, complete the orbit. The superior orbital fissure is one of the main structures of the orbit. It is a foramen on the border of the upper and outer walls of orbit, lying between the lesser and greater wings of sphenoid bone. This here, yes. There are two conditions which you need to know during this lecture. It is exophthalmos and enophthalmos. Exophthalmos, it is a displacement of the eyeball in front of its protrusion. Enophthalmos is retraction of the eyeball inside the orbit. Exophthalmos outside the orbit. The superior orbital fissure. The superior orbital fissure is here. It is a foramen on the border of the upper and outer walls of orbit. Through this structure pass several nerves and veins. It is all the oculomotor nerves, third branch, fourth branch, and sixth cranial nerves, first branch of the trigeminal nerve, and the upper orbital vein leaves the orbit through this fissure. There is special syndrome due to the damage of the superior orbital fissure, and the structures are going through this foramen. This syndrome is a neurological disorder that results if the superior orbital fissure is fractured. Etiology: it can be tumors, foreign bodies, hematomas, and other. Symptoms of this syndrome are going from those structures which go through this foramina. So the symptoms are moderate exophthalmos, upper eyelid ptosis, complete immobility of the eyeball, mydriasis, paralysis of accommodation, a sharp decrease in the sensitivity of the cornea and eyelid skin. So moderate exophthalmos can be due to the venous blood stagnation. Eyelid ptosis is due to the nervus oculomotorius problems. Complete immobility of the eyeball is due to this damage of this nerve too. Mydriasis is due to the damage of the nervus oculomotorius. Paralysis of accommodation because of the problems with muscles in ciliary body and oculomotor nerve problems. A sharp decrease in the sensitivity of the cornea and eyelid skin. It is due to the problems with nervus trigeminal, the first branch of the nervus trigeminal. So the next is big inflammatory problem, big inflammatory disease of the intraorbital tissue, fat tissue. Name of this disease is orbital cellulitis. It is a diffuse, purulent inflammation of the orbital tissue, followed by the phenomena of necrosis. Etiology of this process are Staphylococcus, Streptococcus, tuberculosis bacterium, Mycobacteria tuberculosis, as well as direct infection of retrobulbar fiber in trauma or surgery. So it is bacterial inflammation. Features are the onset of this disease is acute. The development is rapid within a few hours. There is a severe headache, high body temperature, chills, bradycardia. So there are a lot of not only local but systemic symptoms. Clinical picture. It is big edema and hyperemia of the eyelids. Eyelids are tightly closed. The eye is exophthalmic. Its mobility is limited. Visual acuity is reduced up to the light sensation. The prognosis may be unfavorable, not only for the eye but also for the patient's life, given the development of intracranial complications, cavernous sinus thrombosis. Treatment. Of course, it is organ situation. It must be surgical opening and
You are now muted.
In these cases, the holes of the torn lacrimal tubule are visible at the edges of the wound. Rupture of the upper lacrimal tubule is less common than the lower one. It is difficult and not always possible to restore the tubule's CPD. Wounds of the lacrimal sac and the lacrimal nasal canal are usually found in wounds of the lateral wall of the nose, the inner wall of the eye socket. As a result of injury to the lacrimal nasal canal, strictures are formed in it, which lead as a rule to the development of purulent dacryocystitis. Purulent dacryocystitis can also develop when the lacrimal sac is injured. Here on the picture you see the perforated rupture of the wound of the lower eyelid. Here it is the result of sketching this this kind of rupture. On the lower pictures you see on the left hand the wound, non-perforating wound of the lower eyelid and the result of treatment. The next variant of the injuries of the ocular apparatus of the eye is the conjunctival injuries. They may occur alone or in associated with scleral injuries. The patient complains of pain, lacrimation, photophobia, and sometimes minor bleeding. On examination, a conjunctival wound of various sizes is found, which doesn't gape even with a considerable length. The gaping of the wound indicates concomitant damage to the Tenon's capsule. It's a capsule under the conjunctiva, between conjunctiva and sclera. This size and appearance of a conjunctival wound may not correspond to the severity of the damage to underlying tissue, so thorough examination is necessary. With a small wound of the conjunctiva with good adaptation of the edges, it is possible to limit the use of antibacterial eye drops and ointments, as well as application of an aseptic bandage on the eye. In other cases, primary surgical treatment is required. What about orbit damage? When the orbit is injured, it is necessary to assess bone damage as well as exclude the presence of foreign body in the orbit. Any blunt trauma to the orbit is an indication for X-rays. The position of the eyeball is a very important symptom of orbital damage, so we return to the names of exophthalmos and enophthalmos. Let's discuss again. There may be exophthalmos, it is protrusion of the eye, with displacement of bone fragments into the orbit. If there is bone damage with bone fragments displacement into the orbit, there will be exophthalmos. If there is enophthalmos, it is a situation with retraction of the eyeball with divergence of the bone walls, so the bone fragments goes outside the orbit. Enophthalmos can also occur in the later stages after injury, with the development of fiber atrophy. Damage to the orbit may be accompanied by violation of the movement of eyeball associated with paresis of the oculomotor nerves and the muscles themselves and ptosis. I have no picture. 1 second. $16. Okay, let's check. Okay, now on the screen you should see the picture. Do you see it? Do you see pictures now on the screen?
Yes, doctor.
Okay, let's discuss. The first, in the upper line, there are three pictures. The first picture and the second picture are the damage of the conjunctiva, the ruptures of the conjunctiva. The third picture is foreign body on the sclera. No, and the last fourth picture on the line, it is contusion, severe contusion of the eyeball and accelerator apparatus of the eyeball, and there are ruptures in the lower eyelid with hematome. Hematome. Let's see. 17. Eyeball damage. Eyeball damage. Injuries to the eyeball are divided into non-penetrating, as we spoke about. Please switch on the yes microphone. Thank you. Injuries to the eyeball are divided into non-penetrating and penetrating. Non-penetrating injuries of the eyeball constitute to the main part of all so-called microtraumas, the treatment of which is outpatient and usually does not last long, one or a few days. These include foreign bodies of the cornea, conjunctiva, traumatic erosion of the cornea, non-perforated wounds of the cornea, etc. There are some other. On the pictures, you see erosions of the cornea, little line erosions on the first and the second picture, and two rather big erosions. These defects of the cornea, of the epithelium of the cornea, is colored with specific dye named fluorescein, and we can see them using this green dye. Now you see three pictures. On two pictures in the upper line, there are foreign bodies of the cornea. It's black points. It is metal foreign bodies, which are in outer layers of the cornea. We need to take them off using antiseptic. Using the anesthesia, topical anesthetic solutions, and take them off using instruments. On the lower, there is another picture, the third picture, on the lower line. There are multiple foreign bodies, on the surface of the eyeball, on the cornea, on the conjunctiva. There are multiple foreign bodies. 19. Okay, penetrating eye injury. These diseases are severe and range from 35 to 84% of the total number of eye injuries treated in the eye hospitals. Very wide range. Caused by metal fragments, pieces of glass, cutting, and stabbing tools. In the case, the injuring object dissects the capsule of the eye. The injuring object dissects the capsule of the eye. Penetrating eye injury means that there is the dissects in all layers of the eyeball. The type of penetrating wounds depends on the location of the incision of the fibrous capsule. They can be corneal, limbal, scleral, and mixed corneoscleral, for example. Corneoscleral. There are specific signs of penetrating injury. They can be absolute and relative. Absolute signs of penetrating injury, if we have one of them, it means there is penetrating injury absolute. If we have one or several relative signs of penetrating injury, it means it can be penetrating injury or it can be something else, some other diseases of the eyeball. So, absolute signs of penetrating injury are, there are 5. First, penetrating wound of the cornea, prolapse of the inner membranes in the wound, the presence of a wound channel in the lens, foreign body inside the eye, and traumatic coloboma of the iris. It's a traumatic wound in the iris, mostly round or circle wound. What about relative signs of penetrating injury? It can be uneven, shallow, deep anterior chamber, hemorrhages in the cavity of the eye or in the membranes, segmental clouding of the lens, eye hypertension, pupil shape changes. All these signs can be in the case of penetrating injury and in the case of other diseases of the eye. Here on the picture, you see the damage of the cornea. It is corneal wounds, penetrating corneal wounds on the first, second, third, corneal scleral wound on the fourth picture. So there is a penetrating traumatic channel in the cornea or penetrating corneal wound on these pictures, on all these pictures. Next. 22. Here we see on the first upper line, the first picture, it is penetrating wound of the sclera. On the second, there is opening wide wound in the sclera, and in this wound we see the choroid. Also, the third picture shows us the scleral wound in near the limbus, and the iris is visible through this scleral wound. On the in the lower line, the first picture it is corneoscleral, mostly corneal defect, penetrating defect, and there is iris in this wound, corneal wound. On the second, there is a penetrating wound of the cornea. There is bleeding. There is hemorrhage, traumatic hephema in the anterior chamber of the eye. And the last picture it is combined trauma, complex trauma of cornea, of sclera, with bleeding, with hyphema, with disposition of choroid and iris into the wound, and they are visible in the wound. What's it? 23. Here there are pictures of foreign bodies in the anterior chamber of the eye. The upper line you see the different foreign bodies of form and material in the anterior chamber. They are visible using slit lamp, and lateral light, with lateral light also. On the lower line, we see 3 pictures. The first picture, there is foreign body, glass foreign body in the anterior anterior angle of the eyeball. Also, the second picture is something like this, but the foreign body is bigger, and we see it. Also, the third, it is glass, two foreign bodies, glass foreign bodies inside the anterior chamber near the anterior angle of the eyeball. 4. Here pictures of foreign bodies in the eye cavity. They are in the lens. The first, the second, it's foreign bodies in the lens. On the second picture, on the upper line, on the second picture, you see the shadow behind the foreign body. And on the last third picture, you see the collarbone of the iris. It means the round wound of the iris, and behind it in the lens there is foreign body in the lens. 4:25. Here on pictures there are foreign bodies in the eye cavity also. The first picture, it is foreign body of the all these foreign bodies are on the fundus. They are on the background part of the eyeball or of eyeball. They are lying or they are near the retina and optic disc. For example, the fifth picture, lower line, the right picture, the lower line, there is foreign body in the optic disc. Yes, it is non-happy patient. So and on the upper line we see the foreign bodies which are contact with retina and make the wound in the retina, and atrophy around the around the foreign bodies. 26. What clinical methods or other diagnostic methods we can use during the examination of the traumatic patients? What we need to do to diagnosis of intraocular foreign bodies. Firstly, it is clinical methods. It is sight lightening method, the lateral sight lightening method. Also research in transmitted light when we put the beam of light inside the eye through the pupil. Biomicroscopy using slit lamp. Also, we need to use ultrasound diagnostic. And if we speak about X-ray positive foreign bodies, of course, we need to use X-ray. But I need to remember that all blunt traumas of orbiter needs X-ray diagnostic. There is two variant of X-ray diagnostic in ophthalmology. It is first one according to Comberg-Baltin using a specific and aluminum indicator processes. 1 second, please. I'm here. So first, it's according to the Comberg-Baltins using specific aluminum indicator prosthesis and non-skeletal radiography according to WOPT. Two main methods. Mostly we used Comberg-Baltin method. 27. Here on the picture you see the results of X-ray diagnostics according to Comberg-Baltin. The left part of the picture you see the prosthesis of Comberg-Baltin, aluminum prosthesis with specific points, X-ray positive points, and we need to put this prosthesis on the eye. And after that make the frontal and lateral X-ray photo, and using this prosthesis we can locate it, know where is the foreign body located, inside the eye, near the eye, deeply in the orbit, and check in which meridians we can find it in the eye. Eight. Okay, there is something inside the eye. There is foreign bodies inside the eye or in the orbit. We need to remove foreign bodies from the eyeball. So, how to remove magnetic foreign bodies? There are four main ways to remove, four main methods to remove the foreign bodies from the eyeball. First part is the front pass, for the front way, through the anterior chamber and the incision in the cornea. Should remove only those magnetic foreign bodies that are located in the anterior part of the eyeball. From the anterior chamber, iris, posterior chamber maybe, and lens sometimes, with lens, of course. If the foreign bodies in the anterior chamber of the in the anterior part of the eyeball, we see it, and the incision, the wound incision, the injury incision is no, there is no near this foreign body. We need to make surgical incision, take the foreign body and remove it from the eyeball. The next method is de-scleral method. The essence of this method lies in the fact that the fragments located in the posterior part of the eye and in the ciliary body are removed through the incisions in the sclera, made in accordance with the X-ray localization data. Nowadays, we use this method very rarely. Mostly, we use transvitreal way. Transvitreal way helps us to remove the fragments of foreign bodies from the hard-to-reach area. No, it means the pars plana area of the ciliary body, and goes to the vitreous body and takes the foreign body and takes it off, remove it from the eyeball. This method is used when the fragment is located in the posterior pole of the eye, of course. And the last method is direct method, the method of removing magnetic fragments through a non-closing wound in the shell of the eye. It is used only if the foreign body is located very close to the edge of the wound, 1 or 2 millimeters near the wound or in the wound. When it makes no sense to make a few incisions to remove the fragment. For four variants of removing 29. Of course, there are several complications of penetrating wounds of the eye. First, traumatic iridocyclitis. In the clinical picture, 2 or 3 days after the injury, appear pain in the eye and on palpation in the area of the ciliary body. Ciliary body pain. Intensive mixed injection of the eyeball. Precipitates or exudates in the anterior chamber. Can be hypopion also. The color and pattern of the iris changes, posterior synechia can be, etc. So, the clinical picture of acute iridocyclitis, but it comes to the eye in 2 or 3 days after the injury. It causes in cases where iridocyclitis takes on the character of a protrating process and cannot be treated, a progressive deterioration in visual functions may occur to complete blindness or to light perception with incorrect light projection. So it can be very severe iridocyclitis, and treatment can be very hard. Not the same with inflammatory process without trauma. The next complication is endophthalmitis. The injured eye is even more irritated than in the case of iridocyclitis. In addition to a pronounced mixed injection, conjunctival chemosis often appears on the eyeball. When examining in transmitted light, instead of the red reflex of the fundus or pink reflex of the fundus, can be a yellow-green or gray-green reflex here, which indicates the penetration of infection into the vitreous body. So there is the deeper infection than the anterior segment in the vitreous body. An abscess of the vitreous body is formed. Vision is reduced to light perception or to zero. Bleedness. The prognosis is always very serious, of course. If vigorous anti-inflammatory treatment fails and an atrophic process begins, the eye should be enucleated. Enucleated. It means we need to remove the eyeball. Remove the eyeball to make enucleation. The next severe complication of the trauma is 31. The next, it is panophthalmitis. So, panophthalmitis, it is the inflammation of all layers of the eyeball, of all structures. With the rapid development of infection, the inflammatory process can spread to all the membranes of the eye. Pain in the eye increases, swelling and hyperemia of the eyelids, chemosis of the conjunctiva increase, an inflammatory reaction of the orbital tissue appears, and as a result, exophthalmos, limitation of the mobility of the eyeball, also occurred here. The cornea becomes purulent, infiltrated. The anterior chamber is filled with pus, with purulent discharge. The disease is accompanied by general malaise, headache, fever. The prognosis, as with endophthalmitis, is always serious. It's always serious. But about treatment, what we can say here, the treatment of panophthalmitis. Of course, intensive antibiotic therapy. And also surgery. But here the surgery named evisceration of the eyeball. What does it mean? This is excision of the cornea with the liner knife of scissors, followed by scraping of the purulently inflamed inner membranes with a special spoon. That is removing the contents of the eye, and the sclera remains. Enucleation with panophthalmitis can be complicated by intracranial complications, so it is contraindicated. When panophthalmitis comes to the eye, we need to take all layers of the eyeball, all purulent inflamed layers, and take it from the fibrous layer. And the fibrous layer is stay. It is evisceration. Inner tissue of the eyeball must be removed. 33. Okay. And the last and very serious inflammation, sympathetic inflammation. It is a chronic malignant inflammation of the vascular tract of the intact eye, which develops in the presence of sympathetic inflammation in the damaged eye. It proceeds in the form of chronic fibrinosplastic iridocyclitis in an unfavorable course. Despite the posterior synechia, hypotension of the eye is noted, which can lead to subatrophy and even atrophy of the eyeball. Relatively rarely, sympathetic inflammation proceeds as neuroretinitis. In a healthy eye, blurring of the borders of the optic nerve head appears. Peripapillary edema extends to the area of the macula. Due to exudative changes in the choroid, the function in the macular region may convert a grayish-yellow tint. So it's a very severe situation. There is inflammation in the injured eye, and the word sympathetic means that it gives autoimmune reaction from the all our body to the eye tissues, to the choroid melanin cells, and to the lens, which part is which part of the eye was injured. The lens and melanin cells in choroid have antigens which are foreign for all our body, and if there is an injury in these structures, the antibodies or the antigens from melanin cells and from lens goes to the systemic organism, systemic blood, and can cause the autoimmune inflammation. We know that there are not one but two eyes, and systemic sympathetic inflammation means that the inflammation in traumatic in the eye with injury can cause inflammation in the healthy eye, in another healthy eye, and due to the autoimmune inflammation. Of course, we need to prevent sympathetic inflammation, and it can be made with surgery also. The most reliable prevention of sympathetic inflammation is a timely enucleation of the injured eye. Thanks to modern methods of primary surgical treatment, the use of antibiotics and corticosteroids enucleation has become less common, but it can be used nowadays too. But now there are a lot of antibiotics and corticosteroids, and surgery doesn't need so often. When sympathetic inflammation has developed, the injured eye should be enucleated only when it is blind, and should be refrained from enucleation if even a slight object vision is preserved, since this eye may subsequently be able to see better. It will be better. Okay, what about complications more? If we have the injury with metal foreign bodies, can be two variants of metallosis. Siderosis is a severe change that is caused by the presence of fragments containing iron in the eye. And calcosis is an inflammation resulting from intraocular foreign bodies containing copper or brass due to the deposits of copper oxides in the tissues of the eye. Specific changes in the iris and in the lens are presented here. Specific changes in the iris and in the lens. The next part of traumas are blunt trauma to the eye or contusions. The pathogenesis is complex and consists of the direct action of the injuring object, and is also associated with the hydrodynamic impact of intraocular fluids on the tissues of the eye. This causes damage to the membranes of the eye and its contacts. With contusion, the vascular system is damaged. The body develops hemorrhages, edema, ruptures, and displacement of tissue occur. A violation of a capsule of the eye, the lens, the retina. Here on the slide you see different situations after blunt trauma, after contusion. The first picture is hyphema. Hyphema, it is blood in the anterior chamber. The second and the third is hyphema too, but the first and the third are the total hyphema. There is no vision of iris through this hyphema. And on the second, we see the level of the blood. It is partial hyphema. On the fourth picture, we see the iridodialysis. It is when the iris goes from the have the rupture in this root, in his root, and rupture iris between iris and ciliary body. On the last picture, it is a viewing of the anterior angle of the eyeball with gonioscopy lens, and here there is the iridodialysis too. How it is viewing in the gonioscopy lens. Gonioscopy lens. Let's discuss a little bit contusions more. There are, as in all traumas, there are 4 stages: mild, moderate, severe, and extremely severe. So contusions can have also 4 stages of severity. Mild contusion, it can be erosion of the cornea, it can be little damage or erosion of the conjunctiva, and there is no changes of visual acuity and other functions. The moderate stage can be with hyphema, for example, can be with damage of the cornea, also erosion of the cornea, damage of the pupillary edge. With severe stage, there can be the damage, for example, of sclera under the normal conjunctiva. It can be the damage of the iris. It can be iridodialysis. Here also it can be bleeding, not only in the anterior chamber but in the vitreous body too. And the last, the extremely severe contusion, it is damage of all structures of the eyeball. The next part is burns. Before starting this part of the lecture, we need to check your presence. Here I press start. Now you can write your names. I give you 4 minutes. Now it is 3 and 50 minutes, 52 minutes PM, and in 3 and 55 minutes we will stop. You write your names and I speak about burns. Burns. There are thermal, chemical, and radiation burns. According to the severity of pathological changes, there are 4 main degrees of burns. Of course, mild, medium, or moderate, severe, and extremely severe degree of burns. First degree, mild burns. There is a hyperemia of a conjunctiva, superficial erosion, and slight swelling of the corneal epithelium. The second degree, moderate or medium degree, pronounced ischemia of the conjunctiva is characteristic. The mucous membrane acquires a gray tint and becomes dull. Significant areas of turbidity appear in the cornea. It becomes rough and loses sensitivity. The third, severe stage. Severe stage of the burns. In this stage, the cornea looks diffusely cloudy, necrotic, and takes an appearance of ground glass or matte glass. It saves little bit transparency, but not at all. Something like matte glass. The fourth degree, extremely severe degree of burns, characterized by deep necrosis of the conjunctiva and cornea. The cornea acquires a porcelain tint. It totally white. It totally loses the transparency, and of course loses sensitivity in the second stage yet. So 4 stages of the burns, of severity of burns. Pictures. Here you see some complications after burns. First picture with white cornea. It is can be the fourth stage of the burns, and it can be the result of burns in the leucoma of cornea. On the second picture on the upper line, you see the leucoma of cornea with vascularization, with neovascularization of the leucoma. And the lower line, you see three pictures. All of them, first two, it is symblepharon. It is the connection between the conjunctiva of eyelids and the conjunctiva of eyeball conjunctiva, and there is such a fibrous process, proliferative process in this area. And on the third picture, there is also fibrous tissue which grows on the cornea, on the cornea and on conjunctiva. It proliferates and closes the normally transparent tissue of the cornea. What we can do in the situation of we need to stop. Yes, we need to stop. Now it is 3:55 p.m. We stop checking your presence. Okay, about surgical treatment of burns complications. Of course, we can speak about keratoplasty here, but keratoplasty, in the case of neovascularizative leucomas of the cornea, can be non-effective because neovascularization will grow to the new cornea again. Because of this effect, we need to use specific equipment named keratoprothesis. Keratoprothesis, it is the device which we can put inside the leucoma, corneal leucoma, and in the central part of this device there is the lens which is transparent and which can give the chance to the burnt eye to see, to have good visual acuity, but with narrowed visual field due to the only 4 millimeters diameter of the optical part of keratoprothesis. The situations after burns are very hard to treat, and the keratoprothesis is the main device which can use here.